Hello, everyone. This is Scott Gillette, nurse anesthetist with Summa Health System, bringing you the second of my three lectures that I do throughout the anesthesia training program. Today, we will discuss anesthesia for aortic surgical procedures. The objectives for this lecture will include discussing the incidence and risk factors for the development of abdominal aortic aneurysms, compare true aneurysms, pseudoaneurysms, and dissecting aneurysms, describe the major arterial vessels that branch from the aorta, list some of the common coexisting diseases that you will see in patients with vascular disease, discuss the perioperative evaluation of patients presenting for elective AAA repair. We'll define aortic tube grafts, ABI, and ABFs. We'll discuss the management of aortic clamping and unclamping and list the expected changes in hemodynamics. We will describe the differences between supraciliac cross-clamp and infraciliac cross-clamping. We'll outline the anesthetic techniques used for aortic surgery, describe the management of emergency aortic surgery, and describe the anesthetic considerations when an endovascular aortic aneurysm repair is performed. So, for an introduction, the anesthesia for the treatment of aortic aneurysms and dissections can be one of the most technically challenging cases. Comorbidities compound the degree of risk. Therefore, a thorough understanding of anatomy, pathophysiology, the surgical procedure itself, and potential intraoperative and post-op surgical sequelae are needed to provide safe anesthesia to aortic surgery patients. Looking at the definition and types of aneurysms, an aneurysm is an abnormal enlargement or bulging of the wall of the aorta. The types include fusiform and saccular. A fusiform aneurysm is uniform in shape, appearing equally along an extended section and edges of the aorta, whereas the saccular form is a small lopsided blister on one side of the aorta that forms in a weakened area of the aortic wall. These are pictorial depictions of what I just discussed. As far as location, if the aneurysm occurs above the diaphragm, then it is thoracic. If it's below the diaphragm, it's abdominal. And if it occurs in both locations, it is thoracoabdominal. When you look at risk associated with the aneurysm itself, the average growth rate of an aneurysm, both thoracic and abdominal, is about 0.1 to 0.3 centimeters per year. The greater the size, the greater the risk of rupture. When you look at annual risk of rupture based on aneurysmal size, when it's less than 4 centimeters, that risk is only 0.5% or less. As you eclipse the 4 centimeter up to 5 centimeter range, you're as high as 5%, and over 5 centimeters to 6 centimeters, you're in the 3 to 15%, and it just continues with increased risk the greater the size. When you eclipse that 8 centimeter size, your year-over-year risk of rupture is as high as 50%. The general consensus for intervention is somewhere between 5 and 5.5 centimeters. Regarding mortality, if it's a ruptured aneurysm, your risk of dying is up to 90%. The people that do die, their risk is 100%. Sorry, I'll throw a few bad jokes in here every now and then. As far as elective cases, your risk is about 2 to 4%, which is pretty consistent with non-complicated heart surgery. The general consensus, as I mentioned, advocates elective repair, whether you do it via old traditional incisional approach or the more common endovascular approach is that around 5.5 centimeters. Thoracic aneurysms are most often in patients with atherosclerosis. Additional risk factors include hyperlipidemia, hypertension, and smoking. The abdominal aortic aneurysms are significantly more age-dependent, occurring most often in people that are older than 65 years. Additional risk factors for a AAA include being a male, Caucasian, a positive family history of vascular disease, smoking, and the presence of other large vessel aneurysms and atherosclerosis. The incidence of AAA in elderly women are about 1.3%, and men are a much higher 7.6%. As far as symptomatic AAAs, 25 out of 100,000 at age 50, and it goes up to 78 per 100,000 once you are over 70 years. As far as the location of abdominal aortic aneurysms, the most common place for them to occur is below the renal arteries, known as infrarenal, and all the way to the aortoiliac bifurcation. 5% extend above the renal arteries, which are known as the suprarenal. There are three main types of aneurysms. There are true aneurysms, pseudoaneurysms, and dissecting aneurysms. The true aneurysms involve all three arterial layers, which include the tunica intima, tunica media, and tunica adventitia. You have increased wall tension, and the defect may contain thrombus. You also may be predisposed to subsequent dissection. Here is another picture to kind of go through the types of the aneurysms so you can visualize as I continue through the descriptions here. The next one is a pseudoaneurysm. Those are caused primarily by procedures, so they fall in the iatrogenic realm. They're caused by a disruption in the intima and media layers. They're held together by the adventitial layer only. It's contained by the adventitial layer and the surrounding contiguous tissue. They may thrombose or remain in continuity with arterial flow. And here you can see a picture of the false aneurysm, pseudoaneurysm. Next, we move on to dissecting aneurysms. That's where you have a hole in the intimal layer that leaks into the medial plane. It causes compression of the true lumen. You can have a false lumen that forms and may persist, and it will re-enter the true lumen at a distal site. Both obstruction and rupture can occur with the dissecting aneurysms. Therefore, blood pressure control is paramount in the management of these patients. And in that far right picture, you can see the depiction of a dissection. You can see how it tapers off and how you could have a false lumen that forms and have blood flow that would enter from the proximal end and exit at the distal end. Some of the predisposing factors for aneurysms include atherosclerosis, smoking, hypertension, hyperlipidemia. Also, there can be hereditary factors, the changes due to pregnancy, changes with infections, and you can have something that's called a mycotic aneurysm. There can be traumatic causes that interrupt one of those three layers of the arterial wall that can cause an aneurysm, or you can have had prior aortic surgery, which puts you at increased risk for an aneurysm. Next, we have aorto-occlusive disease. It's most often seen at the aortoiliac bifurcation. It's also known as Leriche syndrome. It is progressive in nature and may lead to disabling claudication or limb loss. Patients with aorto-occlusive disease are typically younger than those with AAAs and kind of de facto have a lower perioperative mortality. The abdominal aorta extends from the diaphragm to the aortoiliac bifurcation. Some of the major vessels that come off of the abdominal aorta include the celiac, superior mesenteric artery, renal arteries, inferior mesenteric arteries, common iliac, internal iliac, external iliac, and femorals. There are several mnemonics out there to remember the major vessels that come off of the abdominal aorta. One of my favorites is found at a place called Help Hippo. And if you just Google Help Hippo and major vessels from abdominal aorta, you will find a rather humorous way to remember. And here's a depiction of the vessels that come off of the abdominal aorta and all the way down to the lower leg. So regarding thoracoabdominal aneurysms, there are a few different classification systems out there. The one noted here is the Crawford classification established in 1986. It is a four-class system. Class 1 involves the descending aorta. It extends into the abdomen and involves the renal, celiac, and SMA. Class 2 involves most of the descending thoracic and abdominal aorta. A class 3 involves less than half of the descending aorta and part of the abdominal aorta from which the visceral vessels arise. And the class 4 is confined to the abdominal aorta, but does involve the renal and visceral arteries. Another classification is the DeBakey. That one, the Type 1 involves ascending the arch and descending aorta. Type 2 is confined to the ascending aorta. And type 3 is confined to the descending aorta distal to the left subclavian artery. And then the Stanford classification, that one divides dissections into two types, type A and type B. Type A involves the ascending aorta, and type B does not. And you can see a little cross-reference with the DeBakey types when comparative to the Stanford classification. And this is one of numerous pictures that you could find that would classify this one here using the first one we talked about, the Crawford classification. Next, we'll talk about some of the concomitant comorbidities in patients with arterial occlusive disease. I want to start by saying that the occlusive disease is definitely non-discriminatory. If you have aorto-occlusive disease, you most likely have additional occlusive disease, whether it's peripheral or central. First off, here we're going to talk about coronary artery disease. A large percentage of patients without clinical manifestations of CAD have significant coronary narrowing. Cardiac events are the #1 cause of morbidity and mortality during the perioperative period for all vascular procedures. So next we have hypertension. Long-standing hypertension leads to left ventricular hypertrophy, and LVH increases the risk of subendocardial ischemia and increases myocardial oxygen demand. Long-standing hypertension leads to diastolic dysfunction, potentially increasing the risk of postoperative pulmonary edema. The question here is, should the patients remain on antihypertensive medications when it's time to have their surgery? And I would say absolutely. The one caveat would be patients on ACE inhibitors, while they are great at maintaining pressure and controlling hypertension in the awake patient, when they're under general anesthesia, They are the devil's spawn, and it makes it very difficult for us constantly through the case fighting hypotension. Next, we have diabetes mellitus. Patients with diabetes have substantially increased risk for peripheral and coronary vascular disease. They also have increased incidence of perioperative MI. On these patients, more aggressive perioperative glucose control may improve outcomes and improve wound healing. Chronic obstructive pulmonary disease, often related to long-term smoking. Pulmonary function tests may identify patients at higher risk for postoperative pulmonary complications. Renal insufficiency. Atherosclerosis is the primary cause of renal artery stenosis. Other causes of perioperative renal insufficiency include diabetes and hypertension. Perioperative renal insufficiency increases the risk of postoperative renal failure. Post-op renal failure also increases mortality. On these patients, you need to avoid perioperative dehydration and multiple arterial dye studies. Now we'll move on to the preoperative assessment and PAT needs of these potential train wrecks. Cardiac, obviously, EKG on virtually every patient that comes in for vascular surgery. Additionally, echoes may be indicated, whether it's transthoracic or a TEE. Chest x-rays, based on their clinical history, especially those with lung disease and the COPD that we had just discussed. Other tests would include aortic mapping, either by a CTA, MRA, or some type of 3D reconstruction. Lab work on these patients are relatively basic, other than having disease-specific tests that you may need to add on. You would start with CBC and either a BMP or CMP. Something with a BUN and creatinine would always be necessary for the patients that are having either angiography or endovascular repair because of the likelihood of IVP dye. There are some ways around it with CO2 and things like that, but the studies are not nearly as good as with the dye. And based on their kidney function, that will dictate how much dye they are allowed to have. You're going to want to get coags on these patients due to their likelihood of taking some type of antiplatelet or some type of medication that would cause them to not clot and potentially have further obstruction of their diseased vessels. Listed here are PTINR and a PTT. Additionally, a type and screen at the minimum, and possibly a type and cross match depending on your expected blood loss and their presenting anemia, if any, at the time. Now we'll move on to perioperative management. This slide deals with epidural catheters. Epidural catheters in this population are placed perioperatively for postoperative pain management. They can't be used intra-op during the procedure due to sympathetic blockade. If you were to use it intraoperatively, you give your patient a sympathectomy from the dosing of the epidural, and then they become hypotensive due to hypovolemia, and you have a compounded problem, and maintaining an adequate pressure becomes very difficult. In the postoperative setting, it will decrease your stress response, it decreases catecholamine release, and avoids decreased cortisol levels. Continuing on with the perioperative management, with the open procedures, anything that is thoracoabdominal, you would certainly do a general anesthetic. Venous access, invasive monitoring, multiple large bore IVs on any open procedure. Consider an introducer if you have a known large aneurysm, or if the surgeon were to voice any anticipated difficulties, and then you would also have the ability to float a Swan-Ganz catheter. Arterial line access, you'll see that in both the open and endovascular cases. It's generally in the right arm for thoracoabdominal procedures, because if they have to clamp very high, coming between the aortic root and descending aorta, you have the potential of obstruction of blood flow to the left subclavian. So for maintaining adequate and accurate blood pressures, you would need it in the right arm. As just discussed, another adjunct would be the possible placement of a pulmonary artery catheter. You would reserve this for patients with significant cardiac, pulmonary, or renal disease. With the decision to place a pulmonary artery catheter, you would need to weigh the risks versus the benefits. It inherently has its own risks with the placement and floating of the swan. Now, it can guide treatment in the early postoperative period when you're trying to weigh pressors versus fluid management. Another resource is a TEE. Intraoperatively, it can be more valuable than a PA catheter. You'll see the changes in the wall motion and so forth before you'll see changes in the number in the PA catheter. Regarding open surgical procedures for correction of aortic aneurysms, the first was performed in 1952. The most common surgical approach for abdominal aortic aneurysm or symptomatic aorto-occlusive disease is a vertical anterior midline abdominal incision. A left thoracoabdominal approach may be preferred for aortic procedures involving the visceral vessels, the celiac or SMA, for instance. In some reconstructions involving aneurysms in the chest cavity, a double lumen tube may be needed in order to improve visualization and accessibility and persistent whining from the surgeon. Aneurysm location and concomitant vascular disease help guide aortic replacement graft types. There's a few different types of grafts. The first one, and probably the most common that was used historically, was the tube graft. It replaces the aneurysmal tissue. Healthy aortic tissue is anastomosed to the end of the graft. This graft is typically used for an isolated abdominal or thoracic aortic aneurysm. Next is the aortobiliac graft. A bifurcated graft. The proximal graft is anastomosed to the distal aorta, and the distal ends are anastomosed to the left and right iliac arteries. The procedure can generally be accomplished utilizing a single abdominal incision. Then there's the aortobifem grafts, also called a bifurcated graft. The proximal graft is anastomosed to the distal aorta, and the distal ends are anastomosed to the left and right femoral arteries. The procedure requires both an abdominal incision as well as bilateral groin incisions. This is a depiction of a tube graft that is without any other need for anastomosis other than a proximal and distal defect in the aorta. And this is a aortobiliac graft and then aortobifem. Some of the things intraoperatively: heparinization. Prior to placing the aortic cross clamp, heparin is usually administered to prevent thromboembolic events. The dose is generally around 100 units per kilogram with a target ACT of 2 to 300 seconds. Normal values for an ACT are somewhere between 70 and 180 seconds, depending on your institution. Then heparin reversal with protamine sulfate. Once the cross clamp is removed and circulation is restored, the anticoagulant effects of heparin are usually reversed. The dose is 1 milligram of protamine for each 100 units of circulating heparin. Heparin's half-life is about 60 to 90 minutes, so most people dose protamine using the 60-minute marker. It's, if anything, it's more for ease of math, but the caveat can be when you have to do additional doses depending on the length of the cross clamp time. Generally, redosing heparin would occur every 60 minutes. Your patient may require some postoperative ventilatory support. It would certainly be institution and patient specific. When I have a elective case, I would be much more likely to extubate intraoperatively than an emergent ruptured case. Conservatively, when left intubated post-op, patients are usually weaned from ventilatory support within 6 to 24 hours. When considering extubation, account for the length of the surgery, the amount of blood and IV fluid administration, amount of blood loss, the patient's temperature, their comorbidities, pain management, etc. On to the aortic cross clamp. What to expect in these large open procedures. The aortic cross clamp produces complex physiologic changes. The more proximal the placement of the cross clamp, the more profound the physiologic response. Arterial hypertension will occur regardless of your clamp location, but it is much more profound the higher the clamp is placed. You can expect an increase in central venous pressure as well as pulmonary occlusion pressures. Aortic cross clamp will give you increase in left ventricular wall tension, increased segmental wall motion or abnormalities, a decreased ejection fraction, a decreased cardiac output, increased arterial blood pressure, increased coronary blood flow, and a decrease in your renal blood flow. Now we'll move on to this slide from the Cleveland Clinic and Dr. Roizen. These are the cardiovascular effects of aortic cross clamping and a percentage of change based on the parameter. For instance, mean systolic blood pressure will increase 54% if the aortic cross clamp is placed supraciliac versus just 2% increase if it's infrarenal. It will march out here with pulmonary capillary wedge pressure increases greatly increased with supraciliac versus infrarenal, a much larger decrease in ejection fraction with supraciliac versus infrarenal placement, and you'll see a much increased wall motion abnormality in patients that have a cross clamp placed supraciliac versus infrarenal. And this is just another reference slide so you can see that supraciliac area and where that placement of a cross clamp would be. With placement of the cross clamp, renal blood flow will decrease regardless of whether the clamp is infrarenal or suprarenal. Common sense would indicate that if it was infrarenal, you would still have good renal blood flow, but that is not the case. Renal blood flow decreases up to 38% with an infrarenal clamp. Renal blood flow is completely obliterated during suprarenal clamping until the cross clamp is removed. The incidence of post-operative renal failure is about 3% with infrarenal clamping and 13% with suprarenal clamping. We do have some renal protective measures and trying to minimize the insult to the kidneys. Drug frequently used is mannitol. The dose typically ranges between 0.25 and 0.5 grams per kilogram, which equates to about 12.5 to 50 grams in most patients. and is given before the placement of the aortic cross clamp. It acts as an osmotic diuretic and a free radical scavenger. There are no clinical trials that have shown a decrease in the incidence of renal failure in patients undergoing AAA repair that have been given mannitol, but again, it is used very frequently due to its theoretical benefits. Also, Lasix, the loop diuretic, loop of Henle, if used, it's usually given post-clamp removal, and the dose ranges anywhere from 5 to 10, which would be a renal perfusion dose, to a true diuretic dose of up to 80 milligrams. You need to maintain adequate intravascular volume and cardiac output to promote renal perfusion, and this would make the argument for placement of a PA catheter or a TEE intraoperatively. Metabolic acidosis. You're placing this cross clamp, you're completely obliterating flow, so the lack of perfusion distal to the aortic cross clamp will cause an increase in your acidity. The infrarenal clamp yields no blood flow to the pelvic organs and lower extremities. Suprarenal clamps yields no blood flow to the aforementioned, as well as the liver, stomach, intestines, the biliary system. The higher the clamp, the more detrimental the response. You have anaerobic metabolism, you have stagnant blood flow, metabolic acids and CO2 are produced distal to that cross clamp, but cannot be cleared by the liver or lungs because there's no movement of that blood. While you may see a small amount of acidosis with the cross clamp in place, it will pale to the profound acidosis that will occur when the cross clamp is released. All the stagnant acidotic blood will be mobilized and travel throughout the body, and you will have instant and profound hypotension. How do you manage this? For supraciliac clamping, consider a sodium bicarbonate infusion. With bicarbonate, the end product is a breakdown to carbon dioxide and water. The increase in CO2 can be cleared by increasing your ventilatory rate. You watch your end-tidal CO2 and avoid compounding your metabolic acidosis with a respiratory acidosis. So you can run a low normal end-tidal CO2 in these patients. Your lactate levels will rise following the application of the aortic cross clamp and will peak with removal of that cross clamp and generally return to normal in the early postoperative period. Due to the nature and physiology of aortic cross clamping, higher lactate levels do not coincide with increased mortality as they do with other diseases and traumatic processes, assuming the lactate levels return to normal in the early post-op timeframe. It's if you have patients that have a metabolic process that are increasing their lactate level versus a known instrumentation and something you're going to remove and correct immediately is the rationale behind the rapid correction of your lactate level. For management and correction of the metabolic acidosis, you can implement some corrections in what would normally correct respiratory acidosis. Your ventilation, specific minute volume, should be increased by 25 to 50% before the removal of the cross clamp. This will help to remove both the CO2 produced during anaerobic metabolism and from the hepatic metabolism of the lactate. To reiterate, the higher the clamp, the higher the risk of complications. Renal failure, abdominal and pelvic organ ischemia, increased blood loss, coagulopathies, myocarditis. You can get spinal cord ischemia in these patients. The incidence of spinal cord injury during vascular surgery ranges from a fraction of 1% to nearly 25%. The lower range being with your uncomplicated AAA versus a rupture. With thoracic aortic aneurysms, the incidence of paraplegia is about 3% and can go as high as 10% for paraparesis. What causes the spinal cord ischemia? The blood supply to the anterior thoracolumbar portion of the spinal cord is derived from the radicular artery known as the artery of Adamkiewicz, or the arteria radicularis magna, that supplies blood to the lower 2/3 of the spinal cord. It joins the anterior spinal artery somewhere between T8 and L1, and that occurs in 75%. And then it can be both lower or higher in the other 25% of the population. Has no appearance to make it stand out from other radicular or lumbar arteries. If the cross clamp is applied above the level of the artery of Adamkiewicz, spinal cord ischemia will occur. Even with distal placement of the aortic cross clamp, a steal may occur, causing ischemia and the potential for paraplegia or paraparesis. Getting into some of the preventative measures for spinal cord ischemia. You can do reimplantation of intercostal arteries. Obviously, you want the shortest possible aortic cross clamp times. That goes on many levels, not just for the prevention of spinal cord ischemia, but ischemia to any organ distal to that aortic cross clamp. CSF drainage, you can do this by placement of a spinal drain. That would be done pre-procedure. You're trying to maintain pressures less than about 10 to 15 millimeters of mercury. You can drain up to 10 milliliters of CSF per hour if needed to make that happen. You obviously want to maintain adequate mean arterial pressures. You want the best perfusion possible through the vessels while that cross clamp is in place. You want to maintain normal blood glucose levels. Some of the rare but potential benefits would be epidural or spinal cord or systemic cooling, or additionally some selective shunting or placing the patient on bypass while the grafts are placed. Regarding removal of the aortic cross clamp, what can you expect? The blood pressure will fall. The question is how much. Some of the factors that are involved are pooled blood in the extremities. You will have a degree of acidosis. The longer that cross clamp is on, the worse that is going to be. And the amount of blood loss that you have prior to release of that aortic cross clamp. Preparation is the key. You want to minimize supraaortic cross clamp acidosis. Your volume load, the concept of dilate and fill. Administer vasoactive agents just before the clamp removal. I typically have vasopressin and phenylephrine available. I am definitely giving phenylephrine before that clamp is removed. And you can encourage incremental clamp removal. And the vascular surgeons that I work with, that it's a no-brainer. They're not going to say, hey, okay, we're taking the cross clamp off and take it off and give you back all the lower extremities all at once, because then you'll end up doing CPR on the patient. So what you do is incrementally allow blood flow. So you'll release that cross clamp and maybe allow 25% and then unclamp it halfway and then 75% and then all the way. You're going to need to be on board and have your drugs ready, mixed, and in hand when this cross clamp is So, complications. If this was easy, anybody could do it. You can expect hypertension or hypotension, depending on where you are with placement or removal of that cross clamp. Tachycardia, significant blood loss. My personal best on a ruptured AAA was 21 liters with 40 odd units of blood and blood products returned, not inclusive of cell saver. So you can have some incredible blood loss on these patients. Coagulopathy as you try to balance red cells versus your FFP, cryo, etc. Acidosis, ventilatory difficulties, cardiac compromise and low cardiac output, especially with removal of that clamp, dysrhythmias from the acidosis, hypothermia from the inability to warm the blood and body distal to that cross clamp, and oliguria or anuria. With emergent open aortic surgery, it's typically due to leaking or ruptured aneurysms or failed endovascular procedures. The ruptured aortic aneurysms occur most often in patients greater than 80 years of age. It's 10 times more likely in males, despite a 4-to-1 male to female ratio of having a AAA. In one study, 41% of patients arrived alive in the emergency department. However, overall mortality was nearly 100%. This stresses the absolute urgency of a ruptured AAA. The symptoms: severe pain or tearing sensation in the neck, abdomen, or back. That is your textbook description from the patient. Also hypotension, syncope, or a rapidly expanding. Most of these AAAs rupture into the retroperitoneal space. Typically, you have this triad of pain, hypotension, and a pulsatile mass. The retroperitoneal space is a finite area and permits a tamponade effect. It temporizes your profound hypotension, gives you a chance to catch up. 20% of AAAs rupture into the intraperitoneal cavity. There's no tamponade capability, and you will probably exsanguinate or see those patients exsanguinate and die in front of you. Rarely, about 3 to 4%, the AAA is an aortocaval fistula. Laparotomy and expeditious placement of the aortic cross clamp are the keys to survival. Our management includes a focused assessment. Always start with the ABCs and surgeon presence for rapid laparotomy. You want large bore IV access, probably an introducer, and an arterial line for sure on this patient. Prepare for transfusion. You want type specific cross-match blood as your primary availability. The type specific non-cross-match would be your second wish, and O negative trauma blood if you don't have cross-matched or type-specific blood available. Otherwise, it's Old Faithful, crystalloids, and colloid solutions. You're going to have a cell saver ready, probable activation of a massive transfusion protocol. And with aortic rupture and life-threatening hypotension, you want rapid control, and that is getting that cross clamp into place of the aorta, and that supersedes patient optimization. When your patient's extremely unstable, the surgical team should be prepping the abdomen at the time of induction. This will allow them to do immediate laparotomy as soon as that patient is intubated, and they can get the cross clamp placed as soon as possible. You'll have that critical but stable patient where they have a leak or a contained rupture. That type of patient may benefit from some optimization prior to the induction of anesthesia. The goal of a life-sustaining hematocrit, maintaining normal coagulation, which would involve availability or giving FFP, cryoplatelets, DDAVP, and aggressive fluid resuscitation will provide. Now we're moving on to the endovascular cases. These are the ones that aren't a problem until they are. The first successful endovascular AAA repair was done in 1990 by Dr. Juan Perotti. He began work on the procedure in 1976 and a full 14 years later was finally able to accomplish what he had started. You'll hear a lot of different terms. The EVAR is your endovascular aortic repair. TVAR is a thoracic endovascular aortic repair. And PVAR is your percutaneous endovascular aortic repair. They have significantly shorter recovery times, the option to avoid general anesthesia, a lack of extensive mid-abdominal incision, and lack of exposure to aortic cross-clamping. And that makes this technique a now superior option to many patients. It accounted for 78% of the intact AAA repairs in 2010. That was the last data I could find, but you can imagine 10 years later, we're well ahead of that 78th percentile. Short-term outcomes show EVAR to have a superior reduction in 30-day morbidity and mortality compared to open repair. However, long-term morbidity and mortality as of yet has failed to show any statistically significant difference. Meta-analysis comparing recent studies of endovascular versus open approach shows that in the short term, the patients do much better, but again, long term, they are pretty much the same. And you can see with cardiac short term, 3% versus 11%, pulmonary 4% versus 13%, renal 5 versus 8, the hospital stay 3.9 days versus 10.3 days, and I would argue that that is improved, and it's probably closer to half of that amount of time now, with an ICU stay of a half of a day versus 3.9 days for the open procedure. A bit about the endovascular device itself. The endovascular stents are made of a synthetic reinforced material with a wire mesh frame. This graft is stored in a delivery device, and once it's appropriately positioned endovascularly in the aorta, iliac, or femoral arteries, the stent graft is deployed. The stent covers the entire aneurysm and prevents blood flow into the aneurysmal sac. Procedurally, the distal arteries, such as the femoral or iliac, are accessed through small incisions. You have live fluoroscopy, which allows for visualization and continual evaluation of the aortic anatomy. Following heparinization, the stent delivery system is placed and positioned as clinically indicated in the artery. Following fluoroscopic confirmation of device location, the stent graft is deployed within the vessel. Once deployed, the stent graft immediately obliterates blood flow through the aneurysmal sac. Additional stents are systematically deployed as needed. It's via a stent-in-stent deployment. Finally, following arterial repair at the access site, which actually is rare now because they have these auto suture devices. The heparin is reversed with protamine sulfate, and here we have a couple pictures of the approaches such as EVAR and PVAR for deployment of aortic and aorto bifem biiliac grafts. This shows the delivery systems and how it's stored, and then how it deploys and occupies the space of the aneurysm. Kind of the same picture, but this is a thoracic versus aortic, abdominal aortic rather. And your indications for EVAR, pretty much from the ascending aorta to the iliac and femoral arteries. You can do aortic fistulae, you can repair traumatic aortic injuries, so it is all encompassing now. It largely is dependent on the stability of the patient and the tortuosity of the vessels. Your anesthetic plan technique, you can do a general, you can do a regional with epidural on these ones with the endovascular, or you can do a local or a MAC, a true MAC, where the patient is responsive to verbal stimuli as opposed to the MAC. As far as monitoring, you can have a large bore IV and an arterial line and get by with most cases. You may need a central line or introducer or a PA catheter or a TEE probe. These would be reserved for patients with indicative comorbidities. If the surgeon voices that it's going to be a very complicated procedure or anticipated perioperative problems. When you're deploying grafts proximally with the thoracic grafts, you will need hypotension or a low flow state, possibly momentary asystole for deployment of that graft. That you need that graft to stay in place and you want to minimize forward flow. You can accomplish that with hypotension, with esmolol or nitroglycerin. You may need momentary asystole with adenosine, or you can achieve an ultra low flow state with minimal forward flow by rapid overdrive pacing, like they do when placing the aortic valves with TAVRs. So, anesthetic considerations, we have spinal cord ischemia as a possibility, just like with an open repair. You don't have the cross clamp and risk of ischemia across that artery of Adamkowitz, but you can have spinal cord ischemia with placement of the graft if you obstruct vessels that are accessory or coming off of the aorta. In urgent and emergent situations, you may have to convert to a general anesthetic if the you have a failure of the deployment of the stent, or if you have a massive leak and they can't do a stent in stent, you may have to convert immediately to an open procedure. Blood loss is generally not a concern, but it can be. It can be very insidious or overt. You could have a rupture of the aneurysm, iliac or femoral vessels can rupture, or you can. So stent graft device types, aorto-aortic. This type of stent used to be used a lot, but it had a relatively high rate of failure, so it's not used much anymore. Then you have your modular bifurcated graft. It's the most common one used now for AAAs. Multi-layer stents, branched stents, and fenestrated stents. The fenestrated has openings in it. You would need that the higher up you go, or if even lower, if you're stenting across the renals, you need to have an opening so you can have renal blood flow. And here's a picture of some of the different types of grafts that exist. And remember that those would be inside a delivery device. Here's more pictures of the fenestrated type grafts. You can actually custom make these for a patient based on the location of their vessels that come off of the aorta. The last one that we had custom made was done by the Aborigines in Australia. Even though these are the standard these days, they are not without their own risks and complications. You have risks of infection, access artery injury. You can have contrast nephropathy. There are things you can do to mitigate the nephropathy, like alkalinization of the urine with N-acetylcysteine or Mucomyst. You can have post-deployment ischemia. If you happen to get over a vessel, an accessory vessel coming off of the aorta. Renal, spinal cord, colon, limbs can be affected depending on where that deployment occurs. You can have a post-implantation syndrome. That's caused by a foreign body. It's an inflammatory process that occurs from the foreign object. It's a biochemical response from your body. And then you can have aortic rupture from deployment of that stent. Endoleaks, that's a big one that you'll see. Patients have to get checked for them each year. It used to be via a CAT scan, and fortunately now they're not subjected to all that radiation. It can be done with an ultrasound. There's 5 types of endoleaks. They include, there's type 1 through 5, whether it's an inadequate seal at the proximal or distal graft attachment site, retrograde aortic branch, arterial blood flow into the sac, structural failure of the endograft, stent graft fabric porosity, or expansion of the aneurysm without demonstrable endoleak, which is also called endotension. Cost. A study in 2012 showed the cost of an endograft at just over $14,000 versus about $1,350 for a graft that's utilized with an open repair. So while the endovascular graft cost was exponentially higher due to the decreased length of stay in the hospital, overall costs were relatively close at just over $37,000 for the endovascular group and just under $43,000 for the open repair group. So I have a case study for this. I try to bring some personal involvement in for the lectures that I do. So this was a 30-something patient that was at home and all of a sudden had a tearing sensation in her back, dropped to her knees, screaming for her husband who was outside doing some yard work. He ran inside. And she had a feeling of impending doom. She was transported to Akron City Hospital, and the little caveat there was she was a near-term pregnancy. We were able to ascertain via CAT scan that she had an aortic dissection from the ascending aorta all the way down to the diaphragm, and that's only because we only scanned to the diaphragm to minimize the exposure to radiation to both her and the baby. The decision was made to do an emergent cesarean section on her, and due to her relative stability, to transfer her to the Cleveland Clinic. We got her all lined up, had an uneventful delivery of the baby under general anesthesia, and she went to the clinic and had what's known as an elephant trunk surgery. It is a stage repair of the aorta and may or may not include the aortic valve. Fortunately for her, her aortic valve was intact and had no disruption. But They performed another CAT scan at the Cleveland Clinic, and it turns out that she had dissected not just to the diaphragm, but all the way down to the iliacs. So basically, her entire aorta was involved. They did that elephant trunk surgery. She did well, did have some complications, as most patients do with that because of the extent of it. I would encourage you to kind of go through and read or watch a video on that. It's pretty impressive. This is what it looks like when um, it's during the stages of the procedure. Um, but again, she did have some complications because of the involvement with the arch vessels. She had to have repair to her left subclavian, and then had some problems with steel and cold uh, left arm from time to time. But all things considered, she's alive and able to watch her children grow up.
Hi guys, my name is Abby Gillette. I'm Scott Gillette's daughter. Make sure to wash your hands and stay safe from the COVID-19 virus. I hope you enjoyed my dad's lecture. Bye.
And thank you all for sitting through this voice-over PowerPoint presentation. I know it's tedious on you guys having to sit through these lectures and not be there in person. My daughter was begging me for about the past 50 slides to jump in and do some of the narrating, so I gave her 15 seconds of fame there at the end. If you have any questions, you can direct the emails to Mark Caldwell. He will then forward them to me if it's not something that he can answer on his own. Please do not hesitate to contact me with any questions or concerns. If you want to avoid using Mark as the middleman, my email address is gilletts@sumahealth.org. I will be off until April the 17th, so I should be able to answer questions relatively quickly. Thanks again, and everybody be safe.
Bye.